I'm Mary Dixon-Wells. I have the enormous privilege of being the director of this institute. And this institute is founded on the principle that everyone deserves safe, high quality healthcare and that needs to be supported by reliable, robust evidence. What we do is we generate high quality evidence on what works in improving healthcare, what doesn't, and also very importantly, why. We are characterized by a very highly inclusive approach. We try to combine academic rigor with real world insight. We bring people together to understand challenges, co-design solutions, and to evaluate impact. And a particularly important example of this is the online community we've been developing over the last few months, which is called AVID, the Ambient Voice Innovation and Development Community. Many of you are actually on it already, but it is an online community on a special dedicated platform, completely ad-free for NHS staff, policymakers, and other non-commercial stakeholders. It was born actually out of an idea from NHS England's guidance on AI-enabled ambient scribing from April of last year. And that called for a community of practice to share insights and best practice. And it's now signposted from NHS England. Its important feature is that this is a space for you to collaborate, to share insights, to guide AVT implementation, evaluation, and future development across the NHS. And if you're interested in guiding anyone to it, you'll see it signposted here from NHS England. I guess one question is, why do we need a community like this? Well, many reasons, but one of them is that the evidence base for the benefits of ambient voice technology is still limited, with mixed results actually from many studies. We know that as well as delivering possible benefits, AVT may also have unforeseen short-term and long-term consequences. And critically, there is this need for large-scale coordination and collaboration to support the technology as it evolves.
It's really a real honor to be here to speak to you all today about some of the research our team has been conducting in this area of ambient clinic visit recording. It's an area we've been working in for about 11 years now, before the ambient technologies really came alive and online. And it was lovely for Professor Dixon-Woods to give me an invitation to come. She spent some time at Dartmouth. It was more influential than I think she realizes for many of us, given her rigorous approach to research and the principles that she holds. So thank you again, Mary, for the invite. As you can probably tell by now, I'm not originally from the Upper Valley in New Hampshire. I'm from Texas. Just kidding. I'm from Belfast in Ireland, and I moved to the US around 14 years ago for a postdoc and thought I would be here for a year. And 14 years later, I'm still kicking around doing this sort of work. So let's jump in. First of all, I just want to acknowledge the funders who fund this work, the patients, families, and clinicians who make all this work meaningful and possible, and to the teammates, too many to name, that make all this work possible as well, and also make my life happier and better for being around them. I have no conflicts to declare. Okay, so this is a slide that I've been putting up for a year or two now. All of our visits will be recorded in the next 5 years, and that was stated by Professor Peter Lee. He's a corporate vice president of Microsoft Research, and he stated this back in 2023. This is something that we've been really thinking about in our team quite a lot. And in fact, back in 2018, we conducted a national survey across the US, and we want to find out how common are people recording their clinic visits and for patients to take home and listen back to. And what we found was that about 30% of clinicians in the United States that we surveyed indicated that they had recorded a clinic visit for a patient to use home. Now, according to the dissemination of innovations in healthcare, a tipping point of a new innovation is around 15 to 20%, after which it's difficult. And we the recording reached this point, but it hadn't been taken up. And I think with the birth of large language models, as we'll talk about, and the emergence of ambient recording technologies, that's really the touch paper that's really set this off. So I want to give you a whirlwind tour of how we really got to where we are today. It's important to learn from the past before we move forward to the future. And talk about some of the applications that are possible now with ambient visit recording and some of the ethical challenges that lay ahead that Mary was alluding to. It's really good here. Trusted source of medical information for our patients and our care partners is their clinician. Despite the availability of many technologies now, this still is true. And in the US, patients attend 1 billion healthcare visits a year. That's around 27 or 2,740,000 per day. During these visits, critical information is exchanged that dictates the trajectory of the care that we experience, where we manage all of this care really at home. Now, in order to manage your care at home, you have to remember a lot of information from this visit. Let's just talk about some of the things, particularly older adults have to remember with more complex conditions. So remember to fill their medications, they have to remember to self-administer complex medicine regimens, they have to arrange their appointments, they have to pay their bills, especially in the US. They have to inform their family of what happened in their clinic visit. They have to use medical devices. They have to train their loved ones to assist them on how to use these medical devices. They have to monitor their symptoms. They have to report this back to their clinician, all while actually living with this medical condition. Now, that's a lot. And it can be quite difficult to remember all this information. In fact, up to 80% of information from clinic visits is forgotten. And that's not just among older adults, that's generally across the board. These issues are compounded for older adults by multi-morbidity, as well as our cognition sort of slowly decreasing as we get older. Forgetting this information can really have significant impacts on a person's quality of life and health outcomes. In the US, between $100 and $300 billion of avoidable healthcare costs are attributed to non-adherence to the instructions from the clinic visit a year. Folks are aware of this. It's not like this is a new issue. And in the United States, back in around 2010, through meaningful use, there was policy set in place to support patients taking this information home through something called an after-visit summary, a summary from the visit. It's pretty boilerplate, medicines, diagnosis, a few lines on what was discussed this day. That has since expanded in 2021, the Cures Act, where patients now have access to their patient portal. They can see what the note was that their doctor actually had written about them from that visit. They can see test and imaging results in real time as they emerge, sometimes faster than their doctor can actually tell them. And I know in the UK, there's less of a rollout of this full access to information, but patients do get access to their NHS app where they can see some of this information. Now, this is very helpful and certainly improves transparency and access to this information. However, it still comes with significant challenges. Most of the information written in these notes are not really designed for patients. And so what they say is blah, blah, blah. And in fact, this is a quote from one of the patient partners for one of our research projects, Chronicle. It's like when they give you an after visit summary report, it's like watching a program with half of it missing. Just for context, patient partners, I don't know how common they are in the UK, but in almost all of our research, we have patient partners, members of the community that we do our research with as part of our research team, and really meaningful members of the research team. Audio and video recordings has emerged as a way to try to overcome this deficit in information and barriers to this comprehensive information that is discussed during the clinic visit. It really is a comprehensive record of the clinician's best attempt of communicating complex information with patients. Visit recordings have actually been around for quite a long time. In fact, some of the earliest work by Professor Hack back in the 1970s and 80s, Professor Butt, were when this sort of concept of maybe recording clinic visits and sharing it with patients could help improve a number of outcomes. There's been a number of systematic reviews and scoping reviews over the years, and some of the common themes really do tend to emerge related to when folks get access to recordings, they tend to listen. So they actually will listen to the information and listen back to the conversation that was had. This results in greater recall and understanding of the medical information discussed with the clinician. Patients tend to report being highly satisfied with the visit when they have access. Care partners, that's family members or friends who help support the patient with their care, feel much more engaged in their loved one's care and feel less anxious about their care when they have access to recordings. This can be especially true for family members who can't attend a visit. And we're seeing some signals that access to visit recordings improves mental health outcomes for patients and care partners also. When we have recordings happening during the visit, there tends to be higher quality communication, at least some of that. There's some anecdotal data and some emerging quantitative data to support this. What we have found in our work is that patients tend to reflect on their own performance in the visit. It's really interesting when we have interviewed patients who get access to recordings and we ask them, what are they doing with the recording? One thing they do is listen back to their clinician's advice. But one of the critical things they also do is they listen back to their own performance. Was I a good patient? Did I mention everything to my clinician? Did I forget anything? And they'll re-listen again before their next visit just to check in on what they were meant to do before so they can have a better idea of the conversation to come next. We've also found in 1 or 2 studies that there can be a reduction in patient phone calls to the clinic, so a decrease in burden on the clinical teams. So my research team at Open Recordings, we've been conducting sort of research trying to understand the implications and applications of visit recordings in the US and beyond. We've developed some digital technologies to try to support recording. So this is a system called HealthPal, Health Personal Audio Library, where we can record visits and share it with patients so they can have access to this information, make notes on their visit recording and share it with a loved one. We also have an AI-powered version, which I'll mention just very briefly. This really isn't the focus of the talk today. I just want to give you some context to some of the work that we're doing. But this application is being used by us in all of our clinical trials that we've been conducting. We've been conducting a number of trials, trying to move beyond the prior literature, these prior reviews. The prior reviews tend to focus on recordings of a single visit shared with the patient, whereas our team has been interested in what if we routinely recorded clinic visits and shared them after every visit so that they could listen back. And we've conducted these funded pilot trials, the audio trial, the video trial. You can read more on those papers on those projects here. But I think one of the key things is that we've been finding evidence in our pilot projects to support some of the evidence from the reviews. These pilots have formed a linchpin and basis for larger trials that I'll mention briefly in a little bit. But a key thing is that the visit recording, it provides so much more than a transaction of medical information. And I think that's kind of a fallacy that we have, where we think patients just want the medical information from the visit and that's it. That is not the case. Patients really listen back for a lot more from the visit. They pick up on so much more information from there that we don't really think about. Here are some quotes from across some of our studies. I love this in the top left. I remember interviewing this patient and their husband in Michigan back in 2017, where they were receiving access to visit recordings in primary care. It's actually a fellow Irishman who runs the clinic in that town. But they described this as when they would listen back to their recordings. Together they form a full brain of what is going on. It's such a beautiful quote. Another really meaningful interview that we had conducted was with a patient who had stage 4 cancer. They were dying, and we weren't even too sure if we could interview them, but they really insisted upon sharing their story. And so we went ahead and interviewed them. And they would talk about how they would listen to these recordings, not just for the medical information, but to also listen to the jokes that they would share with their doctor, or to listen to the little nuggets of good news, even though they knew they were dying. And another interesting kind of sad application was that they would give the recording to their loved ones to listen to rather than relaying sort of after every visit what was discussed, because they didn't want to talk about the fact that they were dying. So again, just highlights, there's a lot more here with these recordings. And I think with the ambient recording technology becoming ever present, there's so many applications to consider beyond just that transaction of medical information. So these pilot projects, and for any sort of junior investigators out here, the importance of a pilot project to really form the linchpin of these larger trials is I just can't or overstate that enough. Our team are leading some of the largest clinical trials currently, looking at the potential added value of routinely sharing visit recordings. And so in this study called Replay, funded by the National Institute on Aging, we are randomizing 336 older adults to receive clinic visit recordings in primary care for a period of 1 year versus a control group who are not receiving any intervention. And we're 6 people away from full enrollment. They're just so excited, and it really demonstrates the interest in taking part in a project like this among older adults. In another large trial, we're recruiting 900 older adults and 300 care partners who attend clinic visits with these older adults. And this is a comparative effectiveness study where we are in one group training the patients on how to access their patient portals and optimize their use of this patient portal effectively, versus those getting that training plus visit recordings for 6 months. And again, here we're looking at whether or not this changes the person's quality of life at 6 months amongst these older adults. And of the 900 patients we're aiming to recruit, we're doing really well in terms of our recruitment. We're 547. We had lots of numbers and lots of interest in these studies. I can talk much more about those studies another time or after this presentation with folks who are interested. And then finally, most recently, we received funding to conduct a study of video recording. So we had done a pilot project that I had mentioned earlier, where we video recorded the multidisciplinary clinic visits of people living with ALS. And as many of you will know, ALS is a fatal degenerative condition. After 3 to 5 years of symptom onset, people will pass typically. These patients have these very long, extensive, like 3 to 5 hour visits with up to 12 specialists every 3 months. And so in this project, we are video recording and breaking those visits into chapters so that of 400 people recruited onto the project and their loved ones, we will randomize half of those individuals to get trained again on how to use the patient portal effectively, whilst the other half will get access to video recordings for 12 months where they can review some of this really important information. Of note on our pilot project, what was interesting was we found that people would re-listen or re-watch the PT, the physical therapy, the occupational therapy, and the video recordings with their neurologist. And then another sort of interesting observation in our pilot project, around half of our patients passed away during the study. We just happened to have quite a sick population on the pilot. The care partners kept logging back in to watch videos of their loved ones. So it speaks to potential other application of these recordings for managing loss and grief in this population. So I very quickly went through a lot of the evidence related to the sharing of visit recordings, both audio and video, that's been gathered over the last, almost 50 years now. Yet up until recently, this was not done at scale. And in fact, it's still not done at scale. But what is starting to happen at scale is visit recording through ambient recording. And that has really emerged as a result of large language models and AI that allows us to take these recordings and within split seconds, infer meaning and curate these recordings onto a computer system. So let's just take a quick look at LLMs just as a refresher. I know many of you on this do not need this, but simply we're learning and then it's predicting the cat eats and it can generate the cat eats food. And that's with high predictions. So it's really predicting just the next word in a sentence is essentially what it is doing. I'm not a data scientist, I'm a health service researcher. I work with many talented data scientists. So I've some knowledge, but not a lot of knowledge of the underlying methodologies of these technologies. So there are many really interesting and powerful applications of AI-powered visit recordings. One, which I think most of you are very familiar with, is reduced documentation burden for clinicians. The big potential of recordings to do that. And so, why would we be interested in this? Well, about in 2023 in the US, there was a survey that was conducted and we found that 53% of clinicians reported burnout, 23% say they were depressed. A key driver was documentation and excessive documentation burden was really leading to this. So since this ambient recording has come online where we can record a visit and create the documentation essentially automatically in the back end of the health record system, there's been some promising findings from studies that have been conducted. For instance, this is one of the earlier studies back in 2024, found that clinicians had a positive experience. They reported reduced after hours work. They reported high quality notes. This study was just recently released, it was last month. Interestingly, what they found was that there was indeed a reduced time spent using the health record system for those who accessed and used ambient recording scribes. And this seemed to be actually more pronounced in certain groups: female clinicians with who are advanced practice clinicians, resident physicians, and primary care medical specialists. And those who tend to use the AI scribes more frequently tend to see bigger benefits. However, what was also interesting was that AI adoption was only associated with a 1.7% increase in weekly visit volume for the clinics. So one hypothesis is that if we use this technology, clinicians can see more patients in a given week. There wasn't as much evidence of that happening. And there wasn't as much evidence that this would result in more revenue for the health system. And we're going to revisit these issues later. One other thing that they weren't able to find a statistically significant effect for was the impact on work at home. They didn't see any difference in work at home for clinicians who used AI versus those who didn't. So clinicians still seem to be in the EHR using it at home, but maybe for different reasons. It's an interesting thing to try to explore. And some of you may be familiar. I was reading this paper in preparation for the talk that in the UK there was a study of 17,000 patient encounters, a diverse range of sites across London. And they also found that the use of ambient recording technology, I believe the technology is Tortoise AI in the UK, is pretty widely used. Saw similar benefits to these other papers. One other finding that's starting to emerge is that the use of the technology can actually reduce cognitive burden for clinicians and allow them to focus more on the patient. And I think one of the things that gives us an opportunity for is an emotional reconnection between the patient and the clinician in the room together. So the clinician is not focused on the computer, but they're focused on the patient in front of them. That's a real opportunity available to us if we use the technology correctly. Ambient scribing technology, it is just, there's a cottage industry of companies offering this service. They're growing too quick to count, to be quite honest. If you compare this to the electronic medical record, for instance, it took almost 50 years for the electronic medical record from its inception to it being widely used in the US. It has taken about 5 years at that time frame for this technology to take off in the US and be used relatively widely. I'm a little worried about that timeline and the pace of change, what's driving that change, and what are the potential risks to this, which we're going to talk about shortly. And I think in the UK, it's up to 98% of primary care clinicians have access to a tool such as Tortoise AI that they can use. Another powerful application is the real-time assistance with diagnosis and treatment recommendations. This is one of my favorite titles of a paper, is Speech the New Blood, where people can use the speech from a patient to help predict a range of conditions such as cold, flu, COVID, asthma, psychiatric disorders, neurodegenerative disorders. This sort of technology and these applications are growing and becoming ever more advanced. And in the area of shared decision making, where I do a lot of my research, while it's in its infancy, we're seeing a lot of real-time integration of clinic shared decision making, where tools are available to support patients and clinicians together in their room with access to AI technologies that can help facilitate those conversations. Another application is to help support patients manage and make sense of complex health information. So, as I mentioned earlier, our HealthPal tool, we actually have a more AI forward tool. We used to use natural language processing back in 2017 and 2018 when we first got into this area. We're now moving toward using LLMs for some of these applications. But what we can do is record a clinic visit, and then automatically curate the visit interaction for patients using terms and identifying information in the visit that patients have told us is important to them, such as medical conditions, medications, symptoms, tests and treatment, procedures. So folks can very quickly find those in the visit, and then they can link out to more information to help explain in lay terms what these medical terms mean. Another application, and moving on from our HealthPal tool, is we're working with another funded project from NIA, the National Institute on Aging, with the population of people living with dementia and their loved ones. And we're trying to understand how interpersonal interactions impact patient and outcomes and care partner outcomes. And through this sort of foundational work, we then want to see if we can change our HealthPal recording intervention and target some of the mechanisms that appear to influence outcomes, and then conduct a pilot study where we can test whether or not focusing in on those in an intervention can lead to positive changes within this population. Two of my PhD students, Dr. Maura Onsando and Salar Kalaksadagan, are also exploring the use of recording. So Salar is looking at how we communicate uncertainty in visits. And he's describing the level of uncertainty, the types of uncertainty, and how we respond to uncertainty in visits. And Maura is looking at the sort of racial differences between the experiences of people living with dementia who are Black versus those who are majority white, and whether we see differences in things such as microaggressions, and can we understand why this is emerging. We're also quite interested in psychotherapy. So a lot of the work I do is in depression, some work in anxiety and co-occurring disorders. And I've been curious as to whether or not we can use recordings of psychotherapy shared with patients as an effective way to improve the effectiveness of psychotherapy in the community, because we know that we don't see as effective psychotherapy when it's in the community versus our clinical trials. And so the hypothesis here is that uh, when patients get access to psychotherapy sessions outside the visit, they can be put back in the context of the therapy, re-listen to the important information from their therapist, revisit those golden nuggets, where the value is for the visit, for the therapy, and really get another dose of therapy. If you think about psychotherapy, the words are the medicine. So they can't just go to a pharmacy and pick up another prescription. They just have to wait till their next visit. That doesn't seem like the appropriate approach. So we're trying to build it out this body of work. And in this audio care study, we had patients record 2 therapy sessions and then listen back to them and identify for us where the meaningful moments in therapy are. We also had the therapist do the same thing independently, and then we compared the 2. And so what we were able to find was that there's some similarities and overlap in terms of the increased awareness and insight and validation were 2 big codes that emerged from both the therapist and from the clinicians. These were codes that we applied after reviewing what was highlighted in the therapy session. But there were some differences. For instance, patients highlighted social talk as being important in the therapy session, and that was definitely something that our therapists and our team didn't really land on previously. And so when we interviewed patients about why social talk is important, they talk about this building rapport and trust. And it's a transition to therapy environment. It provides a window into my mindset. So, interesting observations by talking to patients about their recordings and what's valuable in them. And then we can use this to inform applications in the future that target these things. And as part of this project, we have a grant that's been submitted to the NIMH, where we're trying to see if we can predict these moments using the AI technologies that are now available. And we got some promising performances from the models for the grant, and we're hoping to build on that in our future research. Final application I'm going to talk about is about the ability of health systems to use recordings for more than simply the billing and note writing that they're currently being used. And so the models that exist and the applications that are available could be used to assess real-time patient-centered communication on other quality indicators from the conversation that really can automatically identify the performance of the clinician and whether there's room for improvement with how we communicate with our patients. One of the groups I work closely with, the Vermont Conversation Lab, led by Professor Bob Gramling, has been doing some really, really fascinating work in this area. They've been developing open source technologies that can explore the importance of silences in conversations where pauses occur, and are they moments of connection or not? Another thing they look at is the patterns of stories, the phenotype of clinic visit conversations, and do we learn something meaningful from those? So, if you're interested in more of that work, I really would recommend looking at Bob's website. So the bigger application of all this is that in the US, we use the Consumer Assessment of Healthcare Provider Survey that is given to patients, sent out maybe a month after a visit to get their view on their visit. But the responses are pretty low and falling. Only 30% of patients fill out these surveys. Maybe ambient recording technology would offer a more cost-effective solution at evaluating the quality of those interactions. So it would seem that this AI stuff is all pretty magical. It could be it seems to solve all problems in healthcare if we listen to our industry colleagues. And there is like an absolute huge amount of innovation that's possible with these large language models that is incredibly helpful. But it's really important to know that it's not all powerful. And it's really, really, really critical that we understand our limitations. And that's what we're going to really move into in this next part of the talk. But before I get there, oh gosh, I usually do this live, but I guess I'll try my best here virtually. How do you confuse artificial intelligence? And maybe some of you have seen this before. You ask it to differentiate between a blueberry muffin and a chihuahua, and it really, it can really have a hard time in telling the difference. So I used to give the slide in person, and but this was based on the technology from a few years ago. So I ran it through GPT more recently and say, hey, can you actually do this now? I bet you can. And so I asked GPT, can you tell the difference between a muffin and a chihuahua? And it correctly gave me in text, here is the rows and what is what. And so it asked, would you like this, put onto the image? I was like, sure, let's put it onto the image. They couldn't quite label it correctly. So it's labeling everything as a muffin or a chihuahua. I'm not too sure what it was doing. And so I said, no, you've got it wrong. And it said, no, I'll do it again. And so I tried it again. And as you can see, still not quite right. So then I asked if it could do it again, and I got a network error. I broke GPT trying to get it to figure out chihuahuas and muffins. And then after using all the power of a small village in rural Arizona, it explained to me why it was getting it wrong. Well, you know, we create an image based on the image you did, and we get this AI generated image. Would you like us to create an annotator of the original meme with the correct position marked on the original photograph? And I said, of course, that would be wonderful. And it still didn't quite get there. So I think it's a silly example, but I don't think AI is taking over the world just yet. And again, to emphasize, it's really important that we pay attention to its abilities, but also its limitations. And while we can't tell the future of where this is going to go and how quickly it's going to go there, it's really important we scratch beneath the surface and the hype to understand the implications of these emerging technologies. And 5 points to anyone who knows this is Mystic Meg. In the US, no one knows who this is. So we have an ethical obligation, I believe, to patients, clinicians, and the public to consider both the opportunities and the risks of ambient recording technologies. And we really shouldn't take this lightly. As scientists engaged in the study of clinical conversations, my colleagues are enthusiastic about the potential for routine clinical recordings and AI applications to power and improve the quality of healthcare, communication, and delivery. But in order to do so, we must realize, in order to realize the benefits of routine visit recording, it requires the prevention and amelioration of the unintended yet very foreseeable harms that will come to pass. So we're going to go through some of these potential harms. One is burden for clinicians and patients. So the efficiencies gained from the use of these technologies doesn't actually equate to productivity. So we must be careful not to take efficiency from reduced administrative tasks to simply add more work to the clinician's plate. This is a crude approach that will not reduce the burnout problem that our clinicians experience, and it threatens the opportunities to enhance communication between the patient and the clinician in the visit room together. Yet, as I've been hearing more and more from colleagues anecdotally, our clinicians are being told they need to increase the number of patients they see when they're using these technologies, up to 3 to 5 more patients per day. This isn't a quirk, this is actually by design. The ambient recording technologies see this as a real added benefit for the health system, especially in the US, where to see more patients per day adds more to the bottom line for the health system. And while it can reduce burden, we also know that these AI applications hallucinate. They sometimes make up answers that are very convincing, but also very wrong. And while this happens over time, and this seems to happen over time, even when systems initially work well, they start sort of moving into some more hallucinations over time. And so they have to be constantly evaluated. And developers don't really understand why this happens. The big concern with this is that as we use more of this technology, our clinicians may fall into automation bias. We're only human. We will take shortcuts where we can. And if this happens, we may be in a situation where clinicians are following the advice of an automated system without question. And that's a real concern. Philosophically, for the future of healthcare, and I don't mean this with a hyperbole, there really is a risk to the profession of medicine. The repeated delegation of intelligence systems leads not to liberation, but to atrophy and irreversible loss of professional know-how as skills go unused and unrefined over time. We can't take these shortcuts, integrate them into the system without really carefully thinking of how we implement without harming our professions. Issues of fairness also emerge. So it's crucial to address algorithmic biases that frequently and disproportionately affect underrepresented groups of people due to homogeneous, imbalanced, incomplete, or inaccurate or differentially inaccurate training data. years of systematic bias toward minoritized patients will not allow us to quickly address this issue. Commoditization is another concern. So clinical data is required to train algorithms that in turn will be used in healthcare. And AI makers placing monetary value on clinical training data and health systems placing monetary value on trained algorithms, if either or both are entities driven by profit or ownership of intellectual property, this can create circumstances where visit recordings become commodities fueling the development of proprietary AI. And with ambient AI technology, commoditization could appear in other ways. The use of ambient AI could be used by employers or insurers to scrape social media, for instance, and predict the risk of disease for a person. Imagine if your Instagram account was looked at by an employer or by an insurer, where they can use some of this technology to predict this disease risk and then change your premium. This is not like can really happen. It's not a made up risk. And we're starting to see this already, like this, for instance, one of the early applications of AI in clinical encounters was to assist with billing. And latter purpose requires the clinician's judgment about reasonable representations of their work to maintain compliance with payer rules and federal laws. But we need to avoid machine learning and AI tools unintentionally learning to prioritize high yield billing information that fails to honorably represent the clinical work that has been done. This was an article from The Guardian last year, and one of the other applications that they found with these tools was to review claims. And Cigna is being sued because the lawsuit accuses them of reviewing 300,000 claims over 2 months. That's 1.2 seconds per claim reviewed using these algorithms. Yet what they found was that there's a 90% error rate. 9 out of 10 of the denials for reimbursement from a patient were actually, they should never have been denied, but only 0.2% of patients actually go and fight the claim that was denied. And the insurance companies are well aware of this. So there's no incentive for them to stop. One of the main reasons that I mentioned earlier for this uptake in ambient recording technology is for sure to help with our clinicians in the burnout issue. It's beneficial for everyone. However, another issue, especially in the US, is that by using this technology, it is being sold as a way of increasing revenue for health systems by increasing the number of patients that come through the door, and as well by increasing coding complexity. Now, some of the work to date hasn't necessarily shown that that has emerged yet, but I think as this technology is taken up more widely, these are things that we really do have to focus on because it is a key part of the business model for these technologies. My concern when we adopt at such a pace without evaluation or we're driven by profit motives, we may lose opportunities that ambient scribing offers our clinicians and patients. And some of these unintended consequences are really very interesting. For instance, patients are beginning to notice that there's changes in their billing. And this is a quote from a recent article that a patient was checking in at the front desk. One of the staff at the front desk said, "Just so you know, don't discuss any problems while you're in the room, because if you do, we'll change the nature of the visit and you'll get charged for it. So we'll change from an annual wellness to a diagnostic visit, and that will come with a $200 copay." So our staff in the clinics are telling our patients how to act differently in order to avoid being billed. I don't think that was the intention of the tools when they were rolled out. That could then result, particularly in the UK, in the US, with a reversion back to people avoiding care because of the cost of care. And that's a big, big concern. Relatedly, efficiencies from the scalable real-time evaluation of clinic visit interactions, while incredibly helpful, cannot replace the patient voice. We can't be in a situation where just because surveys are not done with high response rates, that we just remove the patient from the equation and we automatically evaluate using a recording. This is a helpful tool, but the patient voice must still be present in healthcare, for they're the reason we have healthcare in the first place. And just as I was thanking Professor Dixon Woods for inviting me, and as I mentioned, she instilled in me and many of us at Dartmouth the importance of rigorously designed studies, clearly defined interventions and the components and the outcomes. A recent review, again, this is just recently released, looked at the 18 studies that have been exploring the use of ambient recording scribes. What it finds is that while ambient recording shows promise of reducing workload and increasing efficiencies and decreasing burnout, current systems still generate high emission rates. Up to 70% of notes generally contain at least one error, and intermittent factual inaccuracies that may affect clinical decision making. Additionally, evidence remains limited by small cohorts of methodological variability. So we really need a ton more work in this area. One thing that I just want to mention is that one of many things, sorry. One of the common refrains from the companies is that we have a human in the loop. Your clinician is in the loop, they will catch things. And it's a reassuring idea. You think about this conceptually. However, put yourself in the position of a clinician. I'm sure there's many clinicians listening here. If you're reviewing your notes and you've maybe seen 10, 15 patients in a day, now as you're reading through the note that was created by the ambient scribe, no doubt a big help. If there was an omission or a factual inaccuracy, it's now upon you to decide whether or not you remember that, whether you agree with what was written, and are you in a position to say, well, I disagree with what was written by the note. How do you remember? You're also prone to like recall bias and forgetfulness as well. So it just creates this real challenge that it feels like it's more of the companies covering themselves by having this as the human in the loop, the clinician's the final sign off, than really trying to address the true problem of these emission rates and factual inaccuracies that occur. I think it's important that we don't forget the environmental impact of all this. All of these tools and these technologies come with a cost to our patients, both financially, but also to the environment. And so what are we doing in the environment with these tools? We are using a lot of energy in order to actually scale and run these systems. In fact, by 2030, we're going to be using slightly more than Japan's total electricity consumption on AI. And these data centers are really the biggest sort of challenge here. As hyperscale data centers are being proposed for 2028, they'll consume up to 60 to 120 billion liters of water. And it's such a concern that companies such as Google are exploring whether or not we can put this infrastructure in orbit around the Earth. This is not like a made-up thing. This is really like where we're at in terms of trying to address this environmental crisis that comes with the technologies. Now, we may develop technologies to help address these. Absolutely. I'm very hopeful that we can do that. But we can't ignore the issue as we roll out technologies. And we have to ensure that what we're rolling out actually makes a difference for someone's life. Not just because we can do it, but because it actually helps. So as I close, preparing for a future with AI-powered clinic visit recordings, I want to bring people back to remember that the patient's the reason for healthcare, not like sort of quirky tools, etc. So we need to really focus on the patient. AI applications should be guided by theory. Just because we can doesn't mean we should. Every time you open an application up, it's another security window, a security door into a health system, and it's more energy being used. We have to ensure we can justify these things. There's some really helpful tools out there that we can use as you're reading up and evaluating if you're a scientist or if you're a health system leader, whether or not you're going to use these tools. Volmer and I'll have a wonderful 20 critical questions tool that was published in the BMJ back in 2020, I'd recommend. And there's a report from the WHO, which personally I found very influential. And I want to leave you with these 6 principles that the WHO has pulled together. It's about protecting human autonomy, promoting human well-being, safety, and public interest, ensuring transparency, explainability, and intelligibility, fostering responsibility and accountability, ensuring inclusiveness and equity, and promoting AI that is responsive and sustainable. These are good principles for us to consider as we move forward in this new world. So with that, I want to thank you so much for your time. I'm sorry if I spoke quickly. I was keen to get through for some questions. And I also want to acknowledge Mr. Roger Arendt. He was one of our patient partners who had been meeting with us weekly for more than 10 years, and he recently passed away. these patient partners mean a lot to us. They're true members of our team, and we miss them when this does happen. So that's me.
Thanks very much, Paul. That was an absolutely fascinating overview of a really complex area. And I was particularly interested to see how you discussed the long history, which I wasn't fully aware of studying recordings of patient-doctor interactions or patient-clinician interactions and patients having access to them separately. And I haven't seen that use particularly described yet in relation to AVT in the UK. We have a very large number of questions, so I'm going to pick out a few and put them to you if that's okay. Because we've got so many, I'll ask for your responses to be fairly brief, but really, really interesting questions. And one of them is about the real-world behavioural impact on clinicians. If consultations are routinely recorded and patients can replay and share them, do we have evidence on whether clinicians change how freely they speak, for example, around clinical uncertainty, safety netting, or sensitive trade-offs? How could it impact on potential litigation risks?
And look, this is a great question, one that we've come across previously and we've done some research on. So, like anything, I have no question that some clinicians could be impacted by being recorded, and they may change a little bit with how they talk. But on a whole, what we have found is that there doesn't seem to be really much change to clinicians' interactions with their patients. They just kind of get used to the idea of being recording. Like in our trials, for instance, after 2 or 3 recordings, clinicians forget it's there. And we study whether there's differences in the interaction. What we have found is that the clinicians, and others have found as well, they have this almost a subtle sense of more accountability, where they pause for a second when they're speaking, maybe a split second. So they're almost more meta-cognitively aware of data they're presenting to their patient. That's really important that they really thought this out before they say it. So if anything, I think it might actually improve the quality of communication. And for patients, similarly, we don't see that our patients change what they're talking about related to sensitive issues. Now, that's not to say sensitive issues aren't important. Gosh, they're incredibly important. One of the minor themes that we found in one of our projects, it was a case study we published recently. This is of 3 clinics across the country in the US that give recordings routinely. Was a worry that patients who had quite traumatic experiences being relayed, re-listening that, could that cause harm? And I think it's a reasonable thing to monitor and explore. From a legal standpoint, we published a paper back in JAMA back in 2019, I think, or 2018. And in the US, the states are governed by these wiretapping laws, which aren't really like purpose-built for healthcare, but it is the laws in which we fall under. And so there's dual party consent states where everyone has to get all party consent, where anyone being recorded must give permission. But that's only 11 of the states. The remainder of the states are single party consent. So, and a patient can just record with their own permission, and that's legally permissible. I would argue it's not acceptable. That's why our team's called open recording. We think transparency is really key. And we know that most patients, when they record, they want to do so with permission. They don't want to hide it, but they do fear about the sort of being told no. And so they'd rather ask for forgiveness than permission because they really want access to this valuable information. And as a final note, there's been some study, there needs to be more of the legal perspective on all this. I'm sure it'll be tested in courts over the years as it starts to emerge more. What was found though is one, malpractice lawyers in a focus group that was conducted probably maybe over 15 years ago, they came to the conclusion that visit recordings would be protective of clinicians because it's an accurate reflection of the clinician's best approach to care. And in Phoenix, Arizona, we studied a clinic there, a neurology clinic, where they offer video recordings. The malpractice insurers there for the clinicians offered a $1 million increase in coverage and a 20% reduction in premiums if they recorded. So it seems like folks find this to be a protective thing for clinicians potentially.
Okay, thank you very much. We've also got a question about the ethical frameworks you used in these studies. You've obviously given us a great overview of many really critical ethical issues in using this. But just briefly, the kind of approach you were taking, obviously we're quite often going into sensitive areas. You had patient partners, not all of whom survived even the study and so on. So just a few brief notes on your own ethical practice in these studies would be great.
Yeah, no, we design all of our projects with patient partners. We do things such as community engagement studios. These are rigorous methods for engaging the community as experts in the design of our research. In our consent forms, we have a double consent. So consent to take part in the research, but then consent to keep the recording for future research purposes. And based on the consent that we have got, in another 2 or 3 years, we'll have around 10,000 unique clinic visit recordings with longitudinal data attached to them, which will allow a broader pool of research to be conducted. But patients can always say no. Clinicians can always say no. Either patient or clinician can veto a recording from that day. They can say, I don't like it, I want to delete it, and we delete it immediately. There's no questions asked. So they both understand this coming into the project.
Okay, great. Thank you. Then we have a question on existing data. AIs are obviously trained on the available data. So they inherit and amplify biases and all kinds of forms of discrimination, which we may be unaware of. Since the systems have been historically shaped around male biology and experience, is there a risk that this kind of bias could carry forward into modern technology? And have you been able to address that as part of your research?
Yeah, so we have been very much on the practical end, especially around the visit recording and making use of the recording for predictions and creation. But I am familiar with, the use of the existing models for things such as predicting skin cancer risk or imaging. And we know in those projects that as a result of the training data, it often misclassifies illness for people with brown and black skin compared to white skin, for instance. We also know that it can make predictions around heart disease risk that can be biased based on pre-assumptions about minoritized patients and their risk for illness. So there are these training data known issues. I would say the NEJM AI journal and their podcast, I can't recommend it highly enough. But they go into a lot of these in some of their episodes, and there's many papers written on that they can refer to. So I'd really recommend you review that for further information. But yes, there are serious issues that are being considered and trying to be addressed.
Excellent, thank you. And last question then. You talked, Paul, about some of the quality challenges that arise in using these technologies, hallucinations, inaccuracies, etc., etc. But I guess one challenge in assessing the quality of the AI scribe generated notes is that we actually don't have a good baseline. Human generated notes are also not necessarily flawless. Any last thoughts on how we address that?
The tough one, isn't it? Well, so one of the challenging things is that in the UK or US at least, when the notes made for the health systems that use these technologies, they don't have access to the recording. That's never shared. They have access to a transcript, but that was automatically generated, so that will have the same omissions and hallucinations in there. No, they seem to be very accurate, but as we see, they make errors constantly as well. So that sounds a bit paradoxical. I think there needs to be more study and more transparency around that data, frankly, because if you're trusting the system and you're spending millions and millions of dollars on using the system in your health system, you want to ensure that that is a quality system, that they're open to being reviewed and having their quality checked, and that there's no sort of black box of, well, we produce something that's high quality and you have to trust us. And frankly, it feels a little bit like that at the moment.
Okay. Well, thanks very much, Paul. That was a really fantastic overview of this area with lots of really thought-provoking insights, comments. I loved the evidence base you presented to us. and thanks for engaging so well in all our questions as well. And to our fantastic audience for posing these questions. If you want to continue the debate, please go to the AVID community where you can join up and be part of dialogue, discussion, and so on. And we will be making Paul's recording available consistent with the theme of the day. So thank you again to Paul. Thank you again to everyone who's joined us, and see you again soon. Take care.
Thanks, folks.